to learn what's really important to them. So, as I've learned in summary, these are the four different management approaches that you may discuss with your doctor after your surgery. So, these include active surveillance, surgery or more surgery, radiation, and chemotherapy. Now, at every stage of testicular cancer, one or possibly more of these options may be pursued. A particular strategy is selected, again, based on both the patient and cancer characteristics that we previously mentioned. Karan, can you walk us through the treatment paradigm you use when treating testicular cancer? Let's start with seminoma, and then we'll progress to non-seminomas while proceeding up the staging ranks from stage 1 to 3 testicular cancer.
Sure. So, as I have mentioned, this is not in any way, shape, or form exhaustive. This is much of an overview of testicular cancer management. You have to make sure that you speak to your oncologist about the particular treatment option that is being presented for you. As we have discussed in stage 1A, so speaking about seminoma, think about a relatively less aggressive testicular cancer. In stage 1A patients, we typically use stage 1A or B, we typically use radical orchiectomy as a measure of treatment. If these patients have already undergone orchiectomy, then we always think about putting them on something called as active surveillance. Active surveillance, I view it as a way of active treatment because this involves relatively intense follow up for the patients, which, given our patient population, can at times be challenging. The reason being that we have to be very, very sure for the first 2 years where the cancer has the highest chance of coming back, and also the surveillance plans stretch over 5 years. So it requires a deep level of commitment from the patient and the caregivers to follow this active surveillance protocol. And we will go into a little bit of detail with that. Now, apart from that, you can have radiation therapy that can be just used to involve a particular portion of the lymph nodes. And also, in some cases, if the surveillance plan is not being followed up, then we might discuss chemotherapy in these patients as well. The next part is stage 1S. This is a similar position where once you have gotten the surgery and you still have tumor markers that are still elevated, this is what we call as micrometastatic disease or cancer in the blood, in which we definitely consider chemotherapy.
So, as you mentioned, stage 1 seminomas have a great prognosis, kind of no matter which management approach you and your doctor decide to pursue up front, your 10-year survival rates are upwards of 99%. So really, the options are just differ by toxicity and slightly by relapse rate, but knowing you can be essentially cured when you pursue that second line of therapy.
That is exactly correct. So, as you mentioned, these patients have amazing survival. So we always make sure that quality of life is at the center of treatment decision making. Just a brief overview of what the active surveillance protocol might look like. So, as I mentioned, in the first 2 years, you do see an intense regimen of imaging, an intense regimen of follow-up within every 4 to 6 months with our patients. And as we go along, that gets spaced out. This is one of the excerpts from the National Comprehensive Cancer Network NCCN guidelines, and every stage has a different type of follow-up. So this is something that we just wanted to share with you as well.